You're listening to Clinical Conversations, a Journal Watch podcast formerly known as Admitting Diagnosis, for the week of April 17th. I'm Joe Elia. Call us at 1-617-440-4374 with your reactions. Let's not have a one-way conversation. As usual, we'll take a cut at the week's news and then start talking. This week's guest is Kimford Meador, whose paper about the late effects on cognitive function of fetal exposure to antiepileptic drugs appears in this week's New England Journal of Medicine. The news first. The most important story this week, for my money, is the one we're lucky enough to have an interview about, antiepileptics' effects on cognitive function. More about that later. Also in the news, but by no means also RANDs, are the following. JAMA published a paper reporting that in type 2 diabetes, the risks for dementia increase with increasing numbers of hypoglycemic episodes. Researchers studied a group of about 17,000 diabetics whose HMO records made it possible to count their hypoglycemic episodes over 20 years. The cohort was subsequently followed for incident dementia for another 4 years. Patients with even a single episode of hypoglycemia over the earlier 20 years showed an absolute increase in risk of about 2.5% per year relative to those patients without hypoglycemia. Next, a reminder. The U.S. Preventive Services Task Force has advised since 1989 that all sexually active women under age 25 be screened for chlamydia. But MMWR reports this week that fewer than half receive the screening. Just a reminder. Finally, in the news, depression after coronary artery disease points to higher risks of heart failure, whether the depression is treated or not. That result was reported in JACC last week. Researchers looked at a large group of coronary patients, 10% of whom had depression diagnosed after their index angiogram. The risk for heart failure was 4 times that of their non-depressed fellow patients. What might cause the association is unknown, but the authors say the public health considerations are considerable. Now, on to our interview. You want to protect the growing fetus from the developmental side effects of drugs. But in the case of epilepsy, it's important as well that mother and fetus escape the side effects of epileptic seizures. Which drug is best, then? Researchers have embarked on a 6-year follow-up of women who took one of 4 drugs during pregnancy for epilepsy: carbamazepine, lamotrigine, phenytoin, and valproate. They are investigating the drug's possible cognitive effects. At the midpoint in their observational study, when the children turned 3, they measured IQ and found that those exposed to valproate had significantly lower IQs than those exposed to the other drugs. The results echo beyond epilepsy, since more than half of the prescriptions written for antiepileptics are for things other than epilepsy, and there's nothing to suggest that non-epileptics are at any less risk for this effect. Dr. Kimford Meador of Emory University's Department of Neurology, where he is a professor of neurology, and the first author on the interim report published this week in the New England Journal of Medicine, has kindly agreed to discuss the work. Welcome, Dr. Meador.
Thank you.
Your paper's introduction says that the most recent consensus guidelines don't distinguish risks among the various anti-epileptic drugs. Has your research now changed the basis for that neutrality, do you think?
I think it's just the most recent ones are pretty old. They go back to the end of the 1990s, and they're being revised. And in fact, there will be published in the next few months guidelines from the Academy, a whole set of new guidelines from the Academy, which my paper is not included because it wasn't published at the time the guidelines were being put together last year. And those guidelines will reflect differences across the drugs as well as a variety of other factors. But at this time, there's still no change. At this point when the publication came out, there's the guidelines are not reflecting it yet, but they're going to change in the next few months.
I see. Now, this was a transatlantic collaboration, wasn't it? You and colleagues in the UK?
Yes, that's correct. I had designed a study back in the mid-'90s, and I was talking to the lead investigator over in England about this. It was a friend of mine, Gus Baker, and he was very interested in it, so I sent him the grant. He submitted there, and actually it was funded there, And subsequently, they lost their funding, and so we folded them into our grant, the U.S. grant that got funded. So it paid off to be nice because we were able to recruit additional patients that way.
Huh. And how many
did make one difference. It did make one difference in that by the time they were folded back in, the one thing that their design was significantly different in is they weren't testing at 2 years of age. We missed a fair number of the 2-year-old kids at England, so there was a smaller number tested at 2 years of age.
Uh-huh.
Our analysis included the 2 and the 3-year-old data, but the sample size is bigger than the 3-year-olds.
And so right now, this report in the New England Journal of Medicine, Dr. Meador, is that it's halfway through. You're at the midway point. You're measuring kids' cognitive function at age 3, and then you're going to measure them again at age 6.
We're actually doing some measurements at 4.5 also. Those are about completed now.
They are.
Let's see, they'll be completed sometime in the next few months. And then the 6-year-olds will be completed in the fall of 2010.
So will you be trying to publish the data on the 4.5?
Probably.
Yeah, I know that you don't want to announce anything at this point, but
I haven't seen the data at 4.5. I can't even tell you.
Oh, good. All right, but I'm sure it would be interesting to see if there's. It's unlikely though that if a measure like IQ changes, it's not going to come back up, is it?
I don't think so. I mean, there is some remedial effects that occur with aging, but I did look at the 2 to 3-year-old IQs, and they were very highly correlated, suggesting that they're not changing very much between 2 and 3. I mean, I would like to be wrong about this, but I'm afraid that they're not going to change, but that's why we're testing them later at 6. There's another reason we're testing at 6, too. I mean, it's a little bit more predictive of school performance because you're sitting right in front of starting school. It's a little bit stronger correlated with the adult IQ. And in addition, at 6, we can do additional testing beyond IQ. IQ is our major outcome measure in the study because it has it's well standardized, and it also has a lot of ecological validity. It's a school predictor. I think people get confused about IQ thinking this is just a measure of all intelligence. It really was originally designed, and its still major purpose is it's a measure for school performance, and it very well predicts school performance. It doesn't come close to measuring everything that our brain does in the cognitive, much less a behavioral standpoint. So we have additional measures. Even at 3, we have some additional measures. We're starting to analyze those data now. But at 6, we have a substantial number of additional measures to try to get a more of a profile of cognitive and behavioral performance in the children.
Now, is the IQ test, do you think, sensitive enough, or is it a fine enough instrument in addition to the other things that you're using to actually see a difference?
Well, apparently it is, because we were able to see the difference.
You think that this difference? But we're talking about 3-year-old kids, and so you think that this difference is real? I mean, would it be likely when these kids are 6 that?
I think it's real. I think it's still going to be there when they're 6. Now, part of this comes from some additional studies that were published previously. There's a fairly large prospective study that was published by the University of Liverpool group that looked at women who had children, and then they had been exposed to different drugs during the pregnancy, and they did testing in them over 6 years of age. And in those kids, the group exposed to valproate had the lowest IQ. Mm-hmm. And then there was a prospective study from Finland. This study had a large carbamazepine sample, which looked quite good. It didn't differ from the control group, but it had a smaller sample of valproate, especially for monotherapy, where there were only 13. And they used mother's education instead of IQ, which it has some limitations. Mm-hmm. But they did see there also a reduction about the same order of magnitude as the retrospective study. So we had those 2 studies published after we began our study, and made us think that perhaps we were going to find a difference with valproate based on those. when we first started our study, actually, the original design did not have valproate in it. It was added later, and we didn't have an a priori expectation that valproate was going to be a bad player in this regard. When these two other studies came out, we started to think that this might be possible. And in addition, in the early part of this century, there were several other studies published from multiple pregnancy registries around the country looking at not cognition, but looking at malformations. And those studies have also pointed to valproate being a drug for risk for not only the cognition that we found in our study, but from congenital malformations. I did a recent meta-analysis that we published, and it showed that valproate was the worst in published data, and that the overall incidence of major congenital malformations was a little over 10%. So 1 in 10 children at risk for major malformations from valproate exposure. In addition, we have from our study that they have increased risk for poor cognitive outcomes, and I think the amount of difference we saw is certainly clinically significant and would have a major impact on a child across their lifetime. Even adding to this worry is not confirmed yet, but a few studies, retrospective studies, that suggest that valproate might even be a risk factor for behavioral issues like autism spectrum disorder.
You said that in your report, you say that one of the things that kind of clinches the association is that most times children's or babies' IQs at that early stage correlate well with their mother's IQs. But in this case, with valproate, they don't.
Right. If you look at population-based studies, the mother's IQ is the most predictive value for the child's IQ. And in fact, if you have a big population study, you put the mother's IQ in a factor analysis, nothing else is significant. You put that in first. And it's not because the baby's IQ is just completely determined by the mother's IQ, but the mother's IQ is associated by other factors, such as father's IQ, such as socioeconomic status, home environment. It's not saying that smart mothers are better mothers, but overall, it kind of drives the effect in the sense of all these other factors that come into regard, maybe more resources, things in that regard that are important for the child's development. Many of the prior studies did not use mother's IQ and when looking at these cognitive outcomes. And that was clearly one of the major factors that we looked at in our study. We also looked at other factors, mother's age, a whole variety of constellation of other factors, some of which didn't turn out to be significant within our population, like other drug exposures or medical illnesses or depression or things like this.
What do you think, Dr. Meador, that clinicians should be doing with this information? Is there a strong enough signal, do you think, that caution is advised here?
Well, what our group has stated is that we don't think the drug should be used as a drug of first choice in women of childbearing potential. Mm-hmm. That doesn't mean it shouldn't be used in women who have potential childbearing, but it is not the first choice. I think there's other choices I would go to before I went to this drug. I think at the minimum, women need to be informed of this. It's just part of the standard informed consent process. Any time we write a prescription, this is certainly a risk issue that a woman needs to know about for the potential of either planned or unplanned pregnancy. I think it's something you have to talk about not after she gets pregnant, because then it's too late.
Yeah.
You have to talk about it before they get pregnant. You need to talk about it when you write the prescription. Right. And valproate is a very effective drug, and for a subset of epilepsy, idiopathic generalized epilepsies, primary generalized epilepsies, it is the one that has been shown to be most effective. It hadn't been tested against all of the drugs that are effective in this regard, but against major other drugs such as lamotrigine and dipyramate, it was more effective in the Sinai study. And in that study, if you look at it, you could estimate that maybe about 15% of women respond to valproate that wouldn't respond to another drug. And so our contention is that you start with one of the other drugs or a couple of the other drugs, and you move your way back to valproate if you need to get control. If you made a mistake and it doesn't control, you can change the drug and fix that, get the seizures under control. If you put the woman on valproate and you make a mistake in the sense that now the child gets a malformation or IQ deficit, that's you can't fix that.
Yeah.
So I would take the more prudent route to me would be to start with something else and move my way toward that. Now, this has to be, in today's world, how we do medicine, is a discussion with the woman, trying to give her informed consent, trying to direct her. So you come up with some situations that are difficult, like a woman's been on valproate, she's well controlled, and she may choose logically not to want to come off the drug because she want to risk. You can't guarantee if you're switching to something else.
Yeah.
But that would be her choice when she's given all the information about the possibility of the malformations and such.
Well, it sounds like your paper will be one of the talking points in those discussions. I want to thank you, Dr. Meador, for your time with us today.
Thank you very much.
We're all ears at 1-617-440-4374. Give us a ring. Finally, Sir John Maddox, who served twice as editor of Nature, died last week. His first stint took place in the days when Nature's cover had that distinctive orange color that you could spot from across the library. It was, if fascinating to read, too expensive for most of us to buy. During his second stint from 1980 to 1995, Nature expanded its news and comment sections and covered everything of interest in basic science and beyond. Maddox was a chain-smoking, ink-stained polymath trained in physics, and his influence in all things scientific was enormous. We'll miss him. Clinical Conversations executive producer is Adore Yano. I'm Joe Elia. Join us next week. Enough said.